Welcome to the third session of the case discussion, management of the chronic renal failure. In the second session, we just discussed the management plan for the hyperkalemia. The questions was mentioned the drugs regimen of choice for treatment of this life-threatening hyperkalemia. ECG changes. So for the drug of choice for the ECG change is intravenous calcium gluconate. And mention the drugs regimen choice for lowering the serum potassium in these patients, and we seen the insulin with glucose plus sodium bicarbonate, and mention the drug regimen of choice for treatment of acidosis, same intravenous sodium bicarbonate, and the role of the sodium polystyrene sulfonate. It is the exchange reagent which replaces the sodium ion with the potassium and decreases the serum potassium level. Let us move towards the next case. Case 4. A 24-year-old woman was diagnosed with stage 5 chronic kidney disease 2 years ago. She started peritoneal dialysis at that time. At a recent clinic visit for a routine checkup, her laboratory values were as follows: sodium in the normal, potassium normal, calcium 155 is hypocalcemia. Calcium is decreased. And if the calcium is decreased, we can say phosphate is increased. Yes, 5.2, hypophosphatemia. And creatinine is increased. What is the drug of best choice for the treatment of life-threatening hyperphosphatemia in these patients? Why? And mention the drug that can be used for prevention of hyperphosphatemia and justify your answer. So here the phosphate level is increased and the calcium is decreased. So let us see the management plan for the phosphate. Hyperphosphatemia, treatment of hyperphosphatemia. There are some dietary measures are also important. Dietary phosphorus should not exceed 800 to 1000 milligram per day. And the source of the phosphates, organic phosphates, are the plant seeds, nuts, legumes, and meats. Inorganic phosphorus are the preservatives and additive salts found in the processed foods. And dark carbonated beverages are common cause for elevated phosphorus level. Hyperphosphatemia increase the phosphate level in the serum, and their consumption should be avoided in the patient with the chronic kidney disease. Dark carbonated beverages means, there are various brands we are using, Cola, Pepsi, like. Avoid phosphorus containing laxatives and enema. And which are the drugs? So these are some dietary measures, but which are the drug of choice? We need intravenous calcium carbonate. Intravenous calcium carbonate is the first line therapy for severe life-threatening hyperphosphatemia. What is the mechanism? Calcium reduces the serum phosphate concentration by chelation. So calcium from the chelation, calcium binds with the phosphate and form the chelation. So calcium reduces the serum phosphate concentration by chelation, and hyperphosphatemia is associated with the low serum calcium concentration. So vice versa. If the phosphate level will be reduced, the calcium level will be increased. And this happens in our case. The calcium level is low and the phosphate level is high. So the first drug of choice is IV calcium carbonate. Let us see other drugs. Oral phosphate binders bind dietary phosphate in the GIT, and these oral phosphate binder must be administered with meals, and this includes oral calcium salts, that is the calcium carbonate, calcium chloride, calcium gluconate, and calcium lactate. All these are the calcium salts, source of calcium, because our aim of therapy bind with the phosphate and chelate it, and this chelation is not able to absorb in the blood. Administered with meals if used as a phosphate binders. And other drugs, fluoroquinolones and oral irons should be taken at least 1 to 2 hours before calcium containing oral phosphate binders. Why? Because fluoroquinolones contain the fluoride and oral iron contain the iron. So these both fluoro and iron form the chelation with the calcium. So, and if we take fluoroquinolones, oral iron, and with the calcium, these are not effective. Fluoroquinolones and ions will be not effective because calcium forms the chelates with these drugs. So it should be taken at least 1 to 2 hours, or give the distance between these two medications to avoid the chelation and to avoid the decreased absorption. Next drug is Sevelamere, is also phosphate binders, and it causes chelation of the phosphate molecules and decrease the serum phosphate level. Lanthanum carbonate also binds with the phosphate molecule and forms the chelate, and not able to, this phosphate molecule is not able to absorb by the GIT. Orally administered aluminum hydroxide antacid. Aluminum antacids are generally used in the management of acidity, as you discussed in the previous block, gastrointestinal, but should be only be used in shorter course, example month, or we can say avoid in the chronic kidney disease patients. Why? Because a small amount of aluminum may be absorbed, accumulate in the patient with the renal failure and the chronic kidney disease due to poor clearance. And if the poor clearance, toxic effect. What is the toxic effect? Encephalopathy, osteomalacia, myopathy, anemia, and dialysis dementia. So aluminum containing products should be avoided in the patient of the renal failure or chronic kidney disease. Some iron-based phosphate binders are also available in hemodialysis patients. ferric citrate, and sucroferric oxyhydroxide. Ferric citrate has the advantage of providing supplemental iron in intravenous iron and erythropoietin stimulating agents used, which improves the anemia. So if the patient having the hyperphosphatemia plus anemia, then you can use iron based phosphate binders, that is ferric citrate. Sucroferric oxyhydroxide available as a chewable tablet and is not systemically absorbed, thus not affecting the anemia management. And the last option is dialysis in acute life-threatening hypophosphatemia if there is acute hypokalemia and the volume overload, the last option. So these are the management for the hyperphosphatemia in the patient of the chronic kidney disease. Let us recall again what was the drugs. Intravenous calcium carbonate is the first line therapy. Then oral phosphate binders, including oral calcium salts, Sevelamere, lanthanum carbonate, and for the iron-based phosphate binders in hemodialysis patients include ferric citrate and sucroferric oxyhydroxides. And the last option is dialysis. So this was the case. And the questions was, what is the drug best of choice in treatment of life-threatening hyperphosphatemia in this patient? Calcium carbonate intravenous. Why? Because it will also improve the calcium level and is the first choice of the drug. And mention the drug that can be used for prevention of hyperphosphatemia. As we discussed, the phosphate binders, oral phosphate binders, calcium carbonate, calcium gluconate, and plus phosphate binder with the ferric components. And this is the last case, case number 5. A 44-year-old African American woman with a 20-year-old history of type 2 diabetic mellitus. She presents to the diabetic clinic for her quarterly checkup. She has been non-compliant with the regular appointment, and her blood glucose has generally remained greater than 200 milligram per dl on prior evaluation, with the hemoglobin A1C 10%, and the goal is less than 7%. So hemoglobin HbA1c is 10.1%, and the goal value is less than 7%. 2 months ago, lately she complains of general nausea, malaise, poor appetite. Physical examination revealed blood pressure 160/102. Hypertension. Bilateral pedal edema. And the laboratory study shows the following results. So serum sodium is normal, potassium normal, serum phosphate increased, slightly increased, serum creatinine is increased, BUN also is increased, blood urea nitrogen 63, it is too much increased, random blood glucose is also increased, hemoglobin 11.3, okay, and urine analysis showed proteinuria increased many times and later quantified as urinary albumin 700 milligram per 24 hours. So albumin is too much increased for 24 hours. What was the question? So this is a case of the chronic kidney patients, chronic kidney disease patients. with the type 2 diabetes mellitus and hypertension. So this patient having the hypertension, albuminuria, and altered blood chemistry, that is the phosphate, increase in the phosphate we just studied. Do you recommend ESA for this patient? Erythropoietin stimulating agents, but here the where is the hemoglobin is 11.3, so we can say, do you recommend? No need to recommend erythropoietin stimulating agents, because I think uh, hemoglobin is 11.3 gram DL, and no need. How can you treat the diabetes for this patient? Diabetes mellitus and pedal edema. So these are the comorbidities of the patients with the chronic kidney disease. For the hypertension, as we discussed in the previous cases, the A categories of drug, angiotensin converting enzyme inhibitors, angiotensin receptor blocker, aliskiren is the best option. For albuminuria, same, angiotensin converting enzyme inhibitors or angiotensin receptor blocker is the best option, as we discussed in the previous case. How can you manage the alteration of the blood chemistry? Here, the hyperphosphatemia, phosphate level is increased. And for this increase in the phosphate level, we can manage by intravenous calcium carbonate, just we discussed. Do you recommend ESA, erythropoietin stimulating agent for this patient? No need, because the here hemoglobin is already 11.3 gram per DL, and if we use this erythrocyte sediment, erythropoietin stimulating agents, it will cause the cardiovascular reactions like the stroke and death. So not recommended. How can you treat the diabetes? Okay, we will discuss this diabetes point. And how can you treat pedal edema? Edema we just discussed. To treat the edema, we need the diuretics, thiazide diuretics, or the loop diuretics are the best options. So remaining is only diabetes. So we will see how can we manage the diabetes in chronic kidney disease patients. Diabetes, yes, here. Management of diabetes in patient with chronic kidney disease. The management of diabetes in the patient with the chronic kidney disease includes achievement of desired HbA1c, and we need here 7%, and in our patient it is 10.1%. Achievement of desired blood pressure, as we know that as per the JNC 8 recommendation, Joint National Committee recommendation, blood pressure should be less than 140 by 90. 140 by 90. So it is about as per the recommendations. And reduction of the proteinuria. Achievement of the desired HbA1c. Generally, uremia is associated with the diminished tissue sensitivity to insulin, secondary to an unknown factor that can be removed by dialysis. So insulin resistance may be due to uremia and inflammation and oxidative stress. Most non-diabetic patients with kidney disease do not require therapy for hyperglycemia, and the dialysis can correct these abnormalities in glucose metabolism. Patients with diabetic mellitus and advanced kidney disease may experience improved glucose control and decrease insulin requirement. Why? Because decreased daily insulin degradation by kidney in the chronic kidney disease. And as the disease progresses, less insulin is cleared and the half-life is increased. So what is the picture? Insulin clearance is decreased. That's why the half-life of the insulin is increased. So we can say yes. So this patient experienced improved glucose control and decreased clearance of insulin by muscle tissue in patient with uremia. So these are the factors in the chronic kidney disease patients. They experienced the improved glucose control. The recommended blood glucose goals in the diabetic chronic kidney disease patients: the fasting blood glucose concentration between 70 to 120 milligram per dl, postprandial blood glucose concentration less than 180, and HbA1c 7%. And targeting HbA1c less than 7% should be avoided. Why? Because risk of the hypoglycemia and without the improvement in the cardiovascular outcomes. But sometimes what happens? The HbA1c values may be falsely low due to decrease the lifespan of the RBCs in the chronic kidney disease. So maybe 60 to 90 days RBC instead of 120 days. So it will give the false low HbA1c value. What is the management plan? Insulin. Insulin strict if the HbA1c is more than 10, start the insulin. Strict glycemic control by insulin, 3 or more insulin dose a day, combination of the basal and bolus, improve diabetic management. It will also decrease the proteinuria, slow the rate of decline in the EGFR, delay the progression of microvascular complication of diabetic. But as we discussed before, decrease insulin clearance in conjunction with the nausea and decrease food intake associated with uremia can lead to hypoglycemia. So, reduced insulin doses are required in chronic kidney disease patient. Why? Because decreased insulin clearance in conjunction with the nausea and decreased food intake associated with uremia can lead to hypoglycemia. In some patients with diabetes, particularly those with residual endogenous insulin secretion, we can say type 2 diabetes, glucose tolerance may normalize as renal function diminishes, eliminating the need for insulin. So if the HbA1c value is more than 10%, the best drug to manage the hyperglycemia is insulin. Other drugs from the category of the sulfonylureas, we can say oral hypoglycemic drugs. Examples are the chlorpropamide, acetohexamide, glyburide, and tolazamide should be avoided in patients with decreased renal function. Why? Because these drugs are metabolized to active product that depend on the kidney for elimination. And if the kidney is not working properly, these drug may leads to the toxic effect, maybe the hypoglycemia, and should be avoided. Instead of this, we can use, so sulfonyl ureas are avoided. Other examples are the glyphosate, gramapyride, and tolbutamide may be used in patients with the decreased renal function. Why? Because completely metabolized to inactive or weakly active product, and it does not affects the kidney or does not depend on the kidney for the eliminations. So glyphosate, glimepiride, and tolbutamide can be used. Other drugs, what about the metformin, which is most commonly used drug in the management of the diabetic? To continue in patient, metformin should be continued in the patient if eGFR is more than 40 ml per minute, but reduce the dose. Metformin should be reviewed in patient with eGFR 30 to 40 ml per minute, but reduce the dose. And this metformin should be discontinued in the patient with the metformin should be discontinued in the patient with the eGFR is less than 30 ml per minute. Why? Because metformin may increase the risk for lactic acidosis in patients, and it is better to control blood glucose in this patient by insulin therapy if the eGFR is less than 30 ml per minute. Metformin should be initiated with care in patient older than 80 years of age. Why? Because of potential low GFR even when serum creatinine is normal. And other drugs, pioglitazone from the category of thiazolidiones. Pioglitazones are primarily metabolized by the liver and are not contraindicated in patients with mild renal failure. So pioglitazone can be used with the low dose. Acarbose, poorly absorbed from the GI tract, should be used with the low dose. And the next category is DPP4 inhibitors. DPP, dipeptidyl peptidase inhibitors, sitagliptins, saxagliptin, linagliptins could also be used, but their doses may require adjustment depending on the degree of renal dysfunction, except for the linagliptin, because linagliptin does not require for the dose adjustment, and you can use it in the patient with the renal failure. Exenatide can be used in patient with creatinine clearance greater than 30 ml per minute, and does not need to be dose adjusted. And the liraglutide should be used with cautions in the renal insufficiency. So these are the options. First important one is insulin, and amongst the insulin, we can use metformin, but the consider the EGFR rate, then pioglitazones, acarbose, linagliptins, exenatide, and the liraglutide. These are all drugs you studied in the previous block, endocrine block. Management of the diabetes mellitus 1 and diabetes mellitus 2. So this is a treatment for the diabetic with the chronic kidney disease. So here the most important is the insulin, then sulfonylureas categories. These are should be avoided, but you can use glypyzides, glimepiride, and tolbutamides should may be used. But some categories of sulfonylureas, chlorpropamide, acetohexamide, glyburide, and tolazamide should be avoided because uh, these drugs are metabolized to active product that depend on the kidney for eliminations. And if the kidney is not able to eliminate, it will produce the adverse effect. So these are the all about the therapeutics or case discussion about the renal failure. I recommend to you this. You should read all this reading material, and you are able to answer the questions as mentioned in the cases. Thank you very much.